from PhRMA, which is the Business Association for the Pharmaceutical Industry in the United States. But I'm actually here today on behalf of the Partnership for Safe Medicines in the United States. And this is about ensuring that patients have access to safe drugs, and they're getting the drug that was intended for them, the drug that was approved by the regulatory agencies with high standards. But often, and sadly, that is not the case. When you think about the pharmaceutical supply chain, the drug is made by the manufacturer, and then it is approved by the regulatory agency. It then goes to the wholesaler or a distributor, and then the drug transfers over to the pharmacy or to the hospital, and then at that point, it gets to the patient. Now you think about the drug going through that supply chain. Every time the drug is moved, there is the opportunity for mischief to take place by deliberate counterfeiters and others who deliberately interrupt that drug supply chain and greatly pose risk to patients. We call this pharma crime. And what we mean by this is the deliberate criminal intent of interfering with the drug supply chain for the purposes of making money, and lots of money in the counterfeit market around the world. This deals with counterfeit medications that are deliberately or fraudulently mislabeled. It's stolen medicines, stealing medicines from the truck as it goes perhaps from the wholesaler to the hospital. And it's also diverted medicines, medicines that may have been approved in one country and then are diverted illegally to go into the market of another country. And what happens here? Patient safety is threatened because patients may purchase directly from unlicensed sources, which is where the counterfeit manufacturers love to put their products. They may purchase from street markets, from non-pharmacy stores, individuals, or the internet, which poses a particular safety concern when it comes to fake or adulterated medicines. Wholesalers may forge documentation. Doctors and pharmacists may unknowingly purchase drugs from counterfeit suppliers. They look legitimate, but they indeed are counterfeit and they're getting the wrong product. And then partially used medications and the packages might be reused and refilled. This has happened in China, where packaging for oncology drugs, injection drugs in the hospital, the packaging was carefully removed and then given to the counterfeiter, and they used that packaging, which looked brand new, to put in fake medicines and then resell that back to the hospitals. Then who are the victims of this so-called pharma crime? And now we have the slides, and I can move up to where I'm at. Hold on. So who are the victims? It's children who get a counterfeit antibiotic when they have perhaps a life-threatening infection. It's diabetics who might be using fake test strips. And this is the point that it's not just about fake or counterfeit medicines. It can be fake and counterfeit diagnostics and medical devices. Cancer patients may get saline solution rather than their chemotherapy. And people with chronic disease, their disease might not be getting any better. Their hypertension isn't going away because their drug is fake or just only with partial ingredient. And just recently in Indonesia, there was a major, drug bust where they found counterfeiters were taking the used vaccine vials from the hospitals and clinics, refilling them and selling them as legitimate vaccines, which caused much harm to children. So what are the keys to tackling pharma crime? One, it's the good work of the drug regulatory agencies and law enforcement activity to identify pharmaceutical crime through inspections and enforcement. You need to have transparency and accountability in government operations, and when counterfeits are found and big drug busts are made to find the suppliers, that needs to be made known to the public and the media. And you need good intelligence and collaboration among regulatory agencies from the central level to the state level, collaboration with police and law enforcement, and with private sector partners. The legitimate drug companies or device companies often are sometimes the first organizations to know that their product has been diverted, stolen, or is counterfeited with fake product in the marketplace. So how do we how do we combat all of this? And it does take partnerships, and that's why the Partnership for Safe Medicines was established in the United States about 8 years ago, and was based on the findings that the counterfeit drug trade is a global crisis. It is a multi-billion-dollar market in the world. Patients lack information and resources, knowledge, and knowing what are the best practices to reduce their risk of encountering a fake or adulterated drug. But there's really, in any country, no single organization that can bring together all the partners and stakeholders that would be needed to really fight against this global crisis. And there is then the opportunity to make sure that patients have access to safe and reliable medicines. So the Partnership the Partnership for Safe Medicines began in the U.S. It now has over 70 partners, and its job is for education primarily, educating of healthcare workers, physicians, pharmacists, and nurses, of policymakers, and to advocate for strong regulatory agencies who have the ability for inspection as well as enforcement of those who violate the drug standards and drug regulations by introducing counterfeits and adulterated products in the marketplace. And we learned then the partnership involves many different stakeholders, from the medical community, from NGOs, the industry, the regulators, the enforcers. They all come together for the interests of patients. And we think about this, that everybody contributes so that all may benefit, and most importantly, it's the patient and the patient safety. Since starting the Partnership for Safe Medicines in the U.S., it actually has now expanded outside the U.S. And based on these principles about securing and protecting the supply chain, particularly looking at the risk of online drug sellers, and then finally unifying the fight against counterfeit and fake medicines around the world. And so now we have partnerships for safe medicines in addition to the U.S. in 3 countries around the world, in India, China, and Indonesia. And the first one to establish was PSM India under the leadership of Bejan Mishra, who is sitting right in the front table with us. Bejan started the Partnership for Safe Medicines in 2010. And it's about working together against spurious and not of standard medicines and to help improve access to quality health care, including quality medicines. PSM India has established itself as a leading voice for the fight for consumers and patient safety and for safe medicines. It has a very excellent website with information to arm patients and consumers to protect themselves and their family. PSM also collaborates with the government on projects to improve the quality of medicines and to ensure regulatory compliance. It also does training and offers knowledge exchange, convening state drug regulators, and convening conferences on quality and security in the drug supply chain. And it also advocates for patient safety to ensure that quality medicines are in national health insurance programs. Based upon the learnings in India, PSM China was established, and that was started in 2012. And it is under the same principles and has the same type of activities as PSM India, and so PSM China really learned from the groundbreaking work that Bejan and his team did here with PSM India. The members in China include pharmaceutical companies, associations, the medical associations, and other health professionals, and also benefit by having the former advisors from the Drug Regulatory Agency in China to help advise the Partnership for Safe Medicines. And PSM Indonesia just began last year. And it began with the strong endorsement of the chief drug regulator in Indonesia, who saw that this partnership, bringing together all the stakeholders, and in this case was led by the doctors and the pharmacists and the nurses, could help support the drug regulator in making sure that the agency is given the resources and the authority to make sure that drugs are safe and of high quality in the marketplace. So that's the story of PSM, our global network from India to China to Indonesia and to the U.S. And I'm really very pleased that these various partnerships are coming together to really build a global network of champions for patient safety and fighters against counterfeit and poor quality medicines around the world. So I think we should be inspired that that we're all in this together to make sure that drugs are safe for patients and that we are protecting the patient welfare in countries around the world. Thank you.
Thank you very much, Dr. Linda. You brought in a different perspective altogether, and I'm happy that today we have people from different stakeholders and different dimensions of quality in terms of development, in terms of manufacturing, in terms of usage of the medical products has actually been brought out. Now we will be running short of time, and when we run short of time, we have to cut down somewhere. And we have spoken a lot about medicines. So what I'll suggest is that now we hear a little bit, and I'll request Rajiv, who speaks for a very long period of time, but today he's going to cut down his speech, and he will draw out a short roadmap for how we need to traverse our journey insofar as quality in medical products, especially the medical devices are concerned. Rajiv.
Thank you, Sharmaji. I know I'm between us and the lunch, and it's near 1 o'clock already. So this is going to be a very snap presentation, because to cut 20 minutes into less than 10 minutes is going to be a challenge. Basically, this is why we are over here, that India has not been regulating medical devices, and now we are going to start regulating medical devices. So a structure is being put into place. The question is, why do we need regulations? And this is the reason. You got traffic over there, you can see jams. Yesterday I nearly missed my flight for that. You got traffic over there. This presentation is running away. It's going too fast.
That's the indication of the lunch.
Yeah, if you can put that timer off for the speed. Yeah. So basically, again, if we will not get disciplined, we cannot enjoy high-speed driving. If the country has to grow fast, if we have to catch up with the world, then we definitely do need to self-regulate, or we need to bring the government to regulate us. You can see Germany over there, they have this law. In case of a traffic jam, and they also do have traffic jams, but you can see the traffic is both on the left side and on the right side. They left the whole middle path empty for the emergency vehicles to come in to clear the accident site. In India, this will become a 5-lane highway from a 2-lane highway. And then we'll have traffic going on the wrong side and blocking the other side also. So that's why we need regulations. And this is our vision. From the regulator side, we would like it to be a center for excellence. At the same time, we don't want it to be policing us. We want to be acting more like a gardener. It should take out the weeds, allow it to be a nice, green, healthy garden. And why do we need this? In medical devices in India, we've got more than 70% import dependency. More than 40% comes from America alone. And then we've got only 15 devices being regulated incompletely and incorrectly as drugs for more than 10 years now. And it's about high time that we started benchmarking our regulations with the best in the world and got aligned with that. So while the government was still thinking as to how to bring around regulations, we already initiated with QCI, and we brought in a system of a voluntary certification for quality. In the morning, you must have heard Mr. Zainul Bhai talking about this. And we also believe that if somebody is going voluntarily for a quality compliance, he'll do a better job. What is going to be done by the government usually is mandatory, is the bare minimal. And when you go voluntarily, you can set your sights much higher up the pyramid. With this as the background, what we created was 3 levels of certification: a basic level of ISO 9000, which was 9000 plus additional requirements, 13485 ICMED, and we will also be coming around shortly with another one, ICMED 13485 plus. This was created by a committee which was having more than 22 departments or organizations as part of it, headed by Dr. Bhan, the earlier Secretary of Biotechnology, and he gave a good leadership to the whole initiative. So basically you have a structure over here. You are mostly familiar with ISO 13485. We've got 23 additional requirements over that, which are mainly on the regulatory side, I would say. And then you got 13 essential requirements, like similarly you have in the EU regulations to address patient safety issues, and 16 labeling requirements to address the concerns of consumer groups like Bijan Mishra for communicating what the needs of the consumers are. And then you've got ISO 9000 plus, or ICMED 9000, which is having additional requirements over the 9000 itself. So in essential requirements, basically what do we have? We've got 6 general requirements and then 7 specific requirements. These are linked to basically, the general requirements are linked to if the product is well designed or not, is it safe or not, is it going to reach the consumer in the original manner or not. And then you've got the labeling requirements, which are a combination of what you already have in the Consumers Act and a combination of what you already have in the Drugs Act. Basic information which a consumer should have access to understand where the product is coming from and how much he should have reliance upon traceability for the quality of the product. What we're trying to achieve is a system where we have minimum intervention from the government, but maximum governance. Internationally, regulations are being unbundled. In India, we've had government who was the legislator, government who was the regulator, government who was the policy maker. The inspector also was from the government. And he would walk into the factory one day and do a surprise inspection, and then the entrepreneur would plead ignorance of law. And then in the evening, he would take consultation from the same inspector. So there was, in the whole system, a complete conflict of interest, which we made certain that the regulations were not being implemented in the right spirit. Internationally, legislation just creates the regulations. There's a regulator whose job is only policy making and regulatory oversight. He does not do the inspections. That part of inspections is unbundled to another organization whose job is to do audits. In medical devices, you've got diverse technologies. Medical electronics is very different from making sterile syringes. Sterile syringes is very different from making orthopedic implants, X-ray machines. One inspector to have knowledge of plastics, MRIs, X-rays, electronics is completely virtually impossible all over the world. So you need specialist auditors in different fields who are being trained and competent in their respective fields and technologies, but following the basic requirement for quality management systems. And this system is then oversight is done by somebody like NABCB. The difference in the system proposed over here is different from what you have in NABL and NABH. In NABL and NABH, you have the system where you have the regulator or the prescriber also being the certifier. In this system proposed, the regulator and NABCB are the supervisors. The certification bodies are independent of that, who will give the certificates to the manufacturers. So there's no conflict of interest over there. The manufacturers will do self-certification first by an audit list. And then we have third-party verification. This ensures that you have a completely clean professional system running, which is completely fair. This ICMET system has now been introduced and is up and running. We saw in the morning and we heard about that quality comes from leadership, it comes from discipline, it comes from culture, it comes from group habits. And to lead the way, my own company was the first company in India to have ICMET certification, and we hope many others will follow. In line with that, we are in dialogue with the government, and the government is now listening to us to have a separate law book than pharmaceuticals, a separate rule book than pharmaceuticals, and this is all job which is underway. And we are requesting to the government that to bring in a concept which will drive Make in India and manufacturing in India. So to traders should not be called manufacturers. The CDSO organization itself, there's definitely room for improvement. The structure which has been there for many years, it needs to be revamped. So good quality, like-minded feedback and suggestions, I'm sure, will help CDSO to now evolve into a better organization, which we propose to be called IHPRA, the Indian Healthcare Products Regulatory Authority, with separate divisions for devices, separate for biologicals, separate for cosmetics, and separate for vaccines. And here again, if the medical device experiment goes good, then maybe even the pharma organizations can also consider moving away from the inspection system to having third-party certification, also for pharmaceutical. The important next part is who regulates whom. And here we had the old structure in place where the center was just doing the policy making and the state was doing everything in terms of regulations. But here we've seen the challenges that for either whether it's a central regulator or the state regulator, to have that dimension and depth of knowledge for regulating such diverse technologies of devices, it's going to be a very big challenge. So even though you may keep the common elements of QMS, design control, certain parts of regulatory issues common, you still do need to delegate over there. So what we had proposed was that the center will just take care of certain issues and the state will take care of certain issues. The center takes care of the manufacturer, the importer, the market authorization holder, and the state takes care of the wholesaler, the dealer, the reseller, the logistics part of it. The job is divided between both of them. The rules have already been drafted. They already have been put up for public comments. These are some of the missing dimensions which we found over there, which we're requesting the Ministry of Health to kindly consider and to add on. Because of paucity of time, I will not go through that list, but it can be shared later on with you. The whole concept being that we need something that we need to go forward and to have Make in India over here. Thank you very much.
Thank you, Rajiv. Thank you very much. In fact, one of the things that we have been doing over the last 2 years is continuous engagement. And therefore, a part of what the government would have said is coming right from the industry. But whatever government says, whatever industry says, the regulator has the final word. And so now I request Dr. G.N. Singh to have the final word before we open it for some questions and answers.
Thank you, sir, for giving me the opportunity. And I am starting where Rajiv ji has left. He has shown a line with a concept Make in India. I remember 2 years back when our Honorable Prime Minister from the Red Fort, he gave a statement, and that always attacks my mind and soul. He told, let India succeed with zero defect on quality. And as a regulator and the people who are sitting over here, we are in process of empowering the consumers. Consumer is going to be the king, and they are going to be the eye and ears of the people of this country. So when I am seeing इतने लोगों को जब हम इस हाल में देख रहे हैं, तो हमें काफ़ी ताकत मिलती है कि हिंदुस्तान की दो जो मजबूत घटक हैं, वो हेल्थ होगा और एजुकेशन होगी. इसमें चूँकि हम हेल्थ से रिलेटेड हैं, इसमें हम लोग का ये प्रयास है कि हम लोग आपको एम्पावर करें, आपको ऐसे ऐसे तौर तरीके दें जिससे आने वाले दिनों में हिंदुस्तान की 125 करोड़ जनता और जो हम फार्मेसी ऑफ द वर्ल्ड बने हैं, जब आप फार्मेसी ऑफ द वर्ल्ड बनते हैं तो चैलेंजेस बहुत बढ़ जाते हैं. उसको मेंटेन करना, सस्टेन करना, उसके प्रति अपनी भागीदारी, जागरूकता बनाए रखना एक बहुत ही चुनौतीपूर्ण कार्य हो जाता है. इसके लिए अभी जब हम इस हाल में आए थे एक हमारी द इकोनॉमिस्ट टाइम्स की करस्पॉन्डेंट ने हमसे पूछा, इज इंडिया प्रोड्यूसेस 2 type of medicine, one for the Indian people, other for the export? I told you no. As a regulator, as scientists, we believe in one quality and we are committed. It is the market only which drive on the other side. Whatever the medicines, the medical devices, the cosmetics or any other products which falls under the medical products, we are maintaining the same quality. We never differentiate in the quality, and that is the fundamental work of the regulators, of the ministry and all the people who are sitting over here. और आप कंज्यूमर को हम ये बताना चाहते हैं कि हिंदुस्तान में कुछ साल पहले ये मिथ रही होगी, लेकिन आज जिस हिसाब से परिवर्तन हुए हैं, जिस हिसाब से रेगुलेटरी लैंडस्केप चेंज हुआ है, फ्रेमवर्क्स बने हैं, टूल्स बने हैं, और हम दावे के साथ कह सकते हैं कि जो भी हिंदुस्तान में दवाइयाँ बन रही हैं वो एक मापदंड के हिसाब से बन रही हैं, सही गुणवत्ता की बन रही हैं, और आप निर्भय निर्भीक होकर उन दवाइयों का सेवन करें और वो आपके स्वास्थ्य वर्धक के लिए हम लोग कमिटेड हैं। इसी दिशा में कुछ दिनों पहले हम लोगों ने पूरे, कुछ लोग गलत भी करने वाले होते हैं, उनको वीड आउट करने का भी दायित्व आपने हमें एज ए रेगुलेटरी बॉडीज सर्वेंट आपने ये काम दिया है कि उसको सही तरीके से पालन किया जाए। हमारे जे साहब बैठे हुए हैं, हमारे माननीय मंत्री जी ने कहा है कि नहीं, हम क्वालिटी पे कहीं कंप्रोमाइज़ हिंदुस्तान में नहीं होने देंगे। कई व्याध्यान भी आए, लेकिन उसको हम लोग ओवरराइड कर रहे हैं। अंतिम चीज़ हम ये बताना चाहेंगे कि कुछ दिन पहले अभी हम BIT रांची गए हुए थे, वहाँ पे हम ये चाहते थे कि हमारे कंज्यूमर जो हमारे पेशेंट हैं इनको कैसे एम्पावर किया जाए, क्योंकि जो पेशेंट सेफ्टी है, उनके राइट्स हैं, उनके वेलबींग्स हैं, जिसके लिए ब्रिजेन जी हमेशा एडवोकेट करते रहते हैं। और आपका ग्रुप का हम आभार व्यक्त करते हैं कि पिछले सालों में ये 3-4 साल में अभूतपूर्व परिवर्तन आपने लाया है, उस दिशा में हम लोग आगे बढ़ रहे हैं। और उसमें हम ये चाहते हैं कि 8 लाख हमारे पास जो सप्लाई चेन की जो व्यवस्था बनी हुई है हिंदुस्तान में, उसको कैसे फार्माकोविजिलेंस प्रोग्राम ऑफ इंडिया, जिसमें आप लोगों ने भागीदारी दी हुई थी, पीछे 2 साल से हम लोग लगातार विजयन जी के साथ मिलकर काम कर रहे हैं, और हम आपकी बड़ी सराहना करते हैं कि आप उस चीज़ को गांव-गांव तक पहुंचाने में सफलता प्राप्त कर रहे हैं। हमारा आपसे अनुरोध है कि ये सफलता और आगे बढ़ाने के लिए हमें एक प्लेटफार्म चाहिए, एक रास्ता चाहिए। वो रास्ता हमें नज़र में आता है जब हम 8 लाख सप्लाई चेन के जो आउटलेट हैं उनके साथ जुड़ जाएं, और आप उसमें अहम भूमिका निभाएं कि कैसे जो दवाइयों के कुप्रभाव हैं, या अगर कोई ख़राब क्वालिटी की दवा कहीं बनती हुई नज़र आती है या कहीं आपके संज्ञान में आती है, तो आप हमें बताएं कि हम तुरंत वहाँ अपने व्यक्ति को, चाहे हमारे स्टेट के रेगुलेटर हों, चाहे हमारे सेंट्रल रेगुलेटर्स हों, हम वहाँ आपके साथ उपस्थित रहें और उपस्थित होकर ये सुनिश्चित कर पाएँ कि कोई भी हिंदुस्तान की जो बनी हुई दवा हिंदुस्तानियों के लिए बनी है, कहीं भी उसमें क्वालिटी का इशू ना हो। भ्रमित हम भी हो जाते हैं। हम जब कोई दवाई लाते हैं अपने घर में, अपने पिताजी के लिए, अपनी माता जी के लिए, अपनी पत्नी के लिए, तो पहले हम देखते हैं कि भैया क्वालिटी ठीक है कि नहीं है। भगवान ने हम लोगों को इस क्षेत्र में काम करने के लिए एक प्लेटफार्म दिया है। हमारी सरकार बिल्कुल कमिटेड है। हमारे जॉइंट सेक्रेटरी साहब, इन्होंने कहा है कि कई बाधाएँ हमारे सामने आती हैं जब हम रेगुलेशन को इम्प्लीमेंट करते हैं। कई बार सब हम खुद डर जाते हैं कि जो कदम हम उठा रहे हैं, कहीं ऐसा तो नहीं है कि भंवर जाल में फंस जाएंगे, लेकिन अंदर से ताकत आप देते हैं, हमारे मंत्रालय देता है, और हम सफलता की सीढ़ी चढ़ते जा रहे हैं। हम आपसे अंत में अनुरोध ये करना चाहेंगे कि कोई भी सक्सेस, कोई भी मुल्क तभी बड़ा होता है जब हम हाथ से हाथ मिलाएं, जब गलतियों को हम अपनी अच्छाई में परिवर्तन करें। हमें पूरा भरोसा है कि जैसे विजयन जी ने प्लेटफार्म जो क्रिएट किया है, क्वालिटी काउंसिल ने जिस तरह से ट्रेनिंग देने का अपना एक लक्ष्य रखा है, क्योंकि रेगुलेशन सबके अपने अपने कार्य निर्धारित हैं, बटे हुए हैं। काला जी यहाँ बैठे हुए हैं, जनुल भाई से हमारी मुलाकात होती है, सिंह साहब जो इनके सेक्रेटरी जनरल हैं उनसे मुलाकात होती है, और हम काफ़ी 2 साल के अंदर परिवर्तन देख रहे हैं। हम आपसे सहयोग की आशा करते हैं और आपसे अनुरोध करते हैं कि पेशेंट सेफ्टी के लिए, उनके राइट्स के लिए, उनके वेलबींग के लिए अगर कहीं भी कोई भी, चाहे वो क्लिनिकल ट्रायल्स हो, चाहे दवाइयों की गुणवत्ता हो, चाहे दवाई की, कभी कभी हम गांव के गरीब आदमी होते हैं, हमें पढ़े लिखे नहीं रहते हैं, अगर दाम लिखा हुआ है 3 रुपया, उसमें चार्ज कर लेते हैं 4 रुपया, फिर सरकार की सारी व्यवस्था वहाँ फेल हो जाती है। हम चाहते हैं कि यू बिकम द आई ईयर्स फॉर द पीपल ऑफ दिस कंट्री। As a regulator, we are committed. Our services would be available at your doors For that, you be rest assured. And we are having a very right type of person sitting on our left-hand side, right-hand side, when such a important people are sitting. They are just symbolic, but you be assured the government is committed, the regulators are committed, and our services would be at your disposal whenever you ask for the patient safety, their rights or well-being. Thank you very much.
Thank you, Dr. Jain Singh. Now I can already see Kalra Sahib is little worried, but we started little late, so lunch will start little late. We'll have some quick questions. You, yes, please. The question should be brief.
Yes.
And if you can identify the panelist also from whom you expect the answer, I think.
Thank you. I'm Dr. O.P. Kansal. I currently work as technical advisor in BD for infection control, patient safety, and injection safety. Sir, the question is not to the panelists, it is to the chairperson, Dr. Sharma ji sir and Jain Singh sir. We were listening, the first presentation by Sandeep was on from the patient's perspective, on the clinical care perspective. And then we switched on to the other speakers talking about the regulatory perspective. I just want to understand that how often does the regulator, like, because you as regulators meet with the regulators like the MCI or the Board of Governors or those kind of bodies who are regulating the clinical practice? Because till that time the two meet and try to streamline their efforts, whatever efforts you are making in ensuring the quality devices or drugs, getting down, how are they matching with the quality of care, health care that is to be given? In the morning session, in the plenary also, there were certain instances, but I just wanted to understand that aspect, that how do you synergize the efforts? Thank you.
Good, thank you very much. As the first presentation was broader, so is your question. But the answer will be short, and the answer is that we are making a new beginning in almost all areas. And the new beginning will be holistic. It will take care of everything that concerns the safety and welfare of the patients. The patient is the prime focus of all that we are planning to do. And lots of activities are being undertaken by the government. They have been identified, some are under discussion, some are under detailed deliberation and analysis, but they will be unfolded in due course of time. It will be too premature for me to tell you because many of the things are already there in a distorted version in public domain. So a lot of things are happening. Patient remains the focus and will remain the focus, and there will be a lot of convergence between regulators, not only on the drugs and medical devices side, not only the Medical Council of India, but even other regulators also, and we are evolving ways of that. Your question, please.
Sir, my name is Dr. Mahesh. I have two questions. First to any of you, but as Dr. Gupta told that the accreditation of clinical trials is going on, and it has been in association with QCI. See, I have been associated with the accreditation of many things. I work for GMP, Institute of GMP, so my natural interest is in accreditation. Please tell me the status of accreditation of these clinical trials and timeline when it will be launched. Second question to Mr. Rajiv. He talked of ISO 9001, 2008. It is obsolete. 2015 has come, please note.
As far as accreditation part is concerned, the issue was examined in detail. The Quality Council of India had come out with a report. The accreditation in respect of clinical trials was to be of the ethics committees, the sites, and the investigators, all the three. Thereafter, we have had some discussions with the people, the stakeholders, and it was expressed by many stakeholders that to begin with, we will start with the accreditation of the ethics committee to begin with, because that is the fulcrum around which the clinical trial processes revolve. So the government has decided that there will be accreditation of clinical, the ethics committees, And there are only a few issues which need to be sorted out, and after that it will commence. It's not that the full framework is ready. There are certain issues, especially the financial aspects, which is holding it back, and we don't want things to be forced. So, but government is very keen on that. The accreditation of ethics committee will start, and once it starts, they will be in a position to do many activities which actually are required to be done. Before we come to this side, I think the question over here, there are, just 1 minute, I think.
The second answer.
Second question, yes.
The answer to your question I'll just give to you. This whole process is completely dynamic, it's never going to stop. ISO 9000 was just revised last year in June when ICMET was under construction. Yes, it's got a 3-year transition time. So the industry and the regulators and the auditors are still trying to understand the implications of ISO 9000. We've been discussing today morning also. So we've got 3 years transition time to learn for that, and then the ICMET will also be revised in due course to update with that in due course of time. Also for ISO 13485, this was revised just now in March this year. Again, it's a 3-year transition period. We have to give time to the industry and to the auditors and to the organizations to get the capacity to comply with that. Thank you.
I would say,
So my
sir.
name is Dr. Chaitanya. My question is to you, Mr. Sharma. In terms of policy, do you see India improving the spending in % of GDP on healthcare? The question I ask is because a lot of our ambitions are really impressive, but in terms of spending, we don't do the same way. So do you see as a policy maker that we are improving that spending? Because as an Indian citizen, I've grown up hearing the news about lack of hospital beds, and whenever I go to AIMS to meet Dr. Gupta, I see a lot of patients from the hospital to the metro station. So can this situation improve?
Okay. I think we will have to be a little brief, and if we focus on the main issue, we will be in a position to answer those issues very briefly also. But as far as the spending on health is concerned, we must have a look at the draft national health policy, which is going to be eventually approved by the cabinet, and you will get what the government's thinking is. You must have also heard about the announcement which PM had made about another scheme. But since this question goes slightly beyond the scope of what we are discussing today, I will take on the next question. Yes, please.
सर myself K.S. परमार फ्रॉम उत्तर प्रदेश. सर मेरा पहला छोटा सा क्वेरी है कि MRP के अंदर जब हम दवा लेने जाते हैं तो रिटेलर के पास उसका कीमत MRP पर हमसे चार्ज करता है, लेकिन पता ये लगता है कि उसकी कीमतों में काफ़ी अंतर है. तो इसका कीमतों का डिसाइड किस लेवल पर होता है, और ये कंज्यूमर को पता नहीं चलता कि वास्तव में दवा में कितना मार्जिन है और कितना हम लोगों से लिया जा रहा है. दूसरा सर, एक सर्वे हुआ था, सैंपल उठाए गए थे पूरे भारत से, उसमें हम लोग भी शामिल थे, और सर्वे के बाद में परिणाम क्या हुए ये आम पब्लिक को अभी पता नहीं है कि उसमें कितनी सफलता प्राप्त की गई और उसका आगे का
आपका प्रश्न नोट कर लिया, बैठे. आपका जो पहला प्रश्न है कीमतों के बारे में, MRP के बारे में, उसमें 2 चीज़ें हैं. एक तो जो प्रोफेसर गुप्ता ने बताया था, नेशनल लिस्ट ऑफ एसेंशियल मेडिसिन बनी हुई है. जितनी दवाएं हमारे देश में बीमारियों को ठीक करने के लिए आवश्यक समझी जाती है, उसकी सबकी एक लिस्ट बनती है. उसकी जितनी लिस्ट बनती है उसमें हमने 376 दवाएं अभी डाल रखी हैं. एक अभी एडिशनल डाला है, उसमें स्टेंट 377 हो गई, और जो 376 दवाएं हैं वो करीब अधिकतर बीमारियों को कवर करती हैं. उसके प्राइस का, कीमत का निर्धारण का कार्य NPPA करता है, और उसका प्राइस निर्धारण अगर आप फार्मेसी वाले प्रोफेशन के लोगों से पूछोगे तो वो काफ़ी क्रिप करते रहते हैं, अक्सर क्रिप करते रहते हैं कि बहुत ही कम दाम पर उसको फिक्स किया गया. तो कीमतों का निर्धारण तो हो रहा है और कीमतें काफ़ी ठीक भी आ रही हैं. आपने बड़ा इम्पोर्टेंट मुद्दा उठाया सर्वे का. जस्ट प्लीज let me answer that part. I'll just come back to that, come back to more questions. But before we move there, we have to have a balance between different portions. And actually, you have moved there? No. Oh, you are here, no? Yeah, so we'll have a question from there. So your second question was about the survey. We had taken up a survey of the extent of quality of medicine in the country, and 47,000 samples had been drawn from all across the country. The survey was not a governmental exercise. The design had been prepared by the Indian Statistical Institute, Hyderabad, a scientific design, a statistical design, and on the basis of that, those samples were picked up. Our inspectors were there, people from the NGOs were there, people from the pharmacy profession were there, and the samples were then analyzed. When the question of analysis came, there was also an issue whether we should do it exclusively in-house or we should do it through the smaller NABL accredited labs also. So we had some of the labs visited. So at that point of time, what we found was that the capacity of the smaller labs, which of course were good for the specific scale and the specific chemicals that they could have analyzed, was not sufficient. So what we did was to procure all the state-of-art equipment and re-equip our laboratories, central laboratories and 3 of the state laboratories, which were actually good in the beginning also and which were NABL accredited. So we re-equipped them, we provided them additional resources in each laboratories up to 35, 40 persons, qualified persons, and the entire testing and analysis was carried out in those laboratories. The results are under compilation. Broad results are already there. Sometimes during the course of next month, we might be releasing the final report also. So what has come out in the survey is that the extent of not of standard quality drugs in India is lesser than the not of standard quality drugs elsewhere in the world. So the largely held perception circulated, magnified many times over, that India is one of the producers of substandard quality of drugs has been proven to be wrong to a considerable extent. So roughly 3.5% of the drugs which have been picked up from the remotest villages where people had to travel for 2 days, not only the people from the pharmacy, from the CDSU and the state inspectors, but also the NGOs and others. They had to travel over 2 days, and they were told right on the day on which they were to move or they were to pick up the sample, which medicine, which sample is to be picked up, and from which chemist or which shop or which hospital or which dispensary or which medical store depot. So the results will be there, but by and large, the results are satisfactory. There will be certain learning lessons from them, but then that is also the reason why we had conducted that survey. The survey is essentially for improving the quality of the medicinal products. Another issue which Dr. Jin Singh did allude to is about the quality control of the processes. Risk-based inspections have been commenced. 72 manufacturers have been already inspected, where their good manufacturing practices compliance, good laboratory practices compliance has been checked. Earlier we had done a similar exercise in case of good clinical practices also. So all that is required, and that is in the knowledge of the government and the regulator for improving the quality of the medical products is being done. All that is not in our knowledge. We are trying to learn from our partners, from our stakeholders. Yes, please.
सर
Here, I think
एक छोटा क्वेश्चन है सर
एक ऐसा करते हैं,
हेल्थ
थोड़ा
केयर
थोड़ा शिफ्ट करेंगे. अभी
health-
इधर से पूछ लिया, उधर से नहीं पूछा,
हेल्थ
उधर
केयर
चलेंगे.
हेल्थ केयर में मेडिकल लेबोरेटरी टेक्नोलॉजिस्ट का बहुत ज़्यादा रोल है, लेकिन क्या अभी तक कोई रेगुलेटरी बॉडी बनी है या बनने वाली है, कब तक बनेगी? क्योंकि बहुत सारे छोटे छोटे बहुत सारे लैब वाले
आप
ट्रेनिंग दे रहे हैं,
समझ
सर्टिफिकेट
गए
बांट रहे हैं
आप
आपको।
पैथोलॉजी लैब
या
डायग्नोस्टिक लैब्स की
मैं
बात
वल्लभ भाई
करें।
पटेल टेस्ट
बैठिए,
में काम करता हूँ।
बैठिए,
जैसे।
आपका
Thank
प्रश्न हमने समझ लिया है। देखिए, आपके प्रश्न का सीधा सा आंसर ये है कि हेल्थ तो स्टेट सब्जेक्ट है। मैंने जिक्र किया था क्लिनिकल एस्टैब्लिशमेंट एक्ट का। क्लिनिकल एस्टैब्लिशमेंट एक्ट एक सशक्त टूल है। सरकार ने, केंद्रीय सरकार ने 4 स्टेट्स के रेजोल्यूशंस के बाद इसको बनाया था। अब इसको अडॉप्ट करना स्टेट गवर्नमेंट का दायित्व है। हमारे यहाँ से मंत्री के लेवल पर, सचिव के स्तर पर, मेरे स्तर पर हर बार परसुएशन हो रहा है कि ज़्यादा ज़्यादा स्टेट्स उसको अडॉप्ट करें। लेबोरेटरीज़ की रेगुलेशन भी उसी कानून में आती है, पर वो थोड़ा सा और विस्तृत मुद्दा है। पर मोटा मोटा मुद्दा ये है कि रेगुलेट हो रही हैं, कम स्टेट्स में हो रही हैं, और स्टेट्स अपना व्यापक कानून बनाना चाहते हैं, हमारे से भी बेहतर बनाने की कोशिश में। जैसे पंजाब को हमने परसुएट करने की कोशिश की, उन्होंने कहा नहीं आपका कानून बहुत बढ़िया है, पर हम आपसे भी बढ़िया कोशिश करेंगे बनाने की। महाराष्ट्र भी इसी इस पर। यस प्लीज।
सर मैं डॉक्टर खान हूँ और यहाँ करीब दिल्ली में 20 साल क्वालिटी वगैरह के साथ काम करने के बाद अपने गांव चला गया हूँ बिहार में जहानाबाद डिस्ट्रिक्ट में एक गांव है, वहाँ पर हूँ सर। जो परसेप्शन है सर वो ये है कि एक ही दवा की दुकान है, वहीं पर दवा अच्छी मिलती है और बाकी कहीं नहीं मिलती। ये परसेप्शन है हर टाउन के अंदर, चाहे पटना हो, चाहे गया हो, चाहे जहानाबाद हो और चाहे गांव हो। ये परसेप्शन है, आई डोंट नो हाउ इट गेट्स करेक्टेड। सेकंड परसेप्शन जो आप ट्रीटमेंट के बारे में कोई साहब बोल रहे थे, जितना MBBS और बड़े बड़े डॉक्टर वहाँ पर हैं, ज़्यादातर उनकी प्रैक्टिस बहुत कम है बनिस्बत उसके जो कि वहाँ पर लोकल डॉक्टर चला रहा है और जाते के साथ वहाँ पर उसको इंजेक्शन देता है, बड़े बड़े इंजेक्शन देते हैं।
चलिए
वो और सर
प्रश्न-
बस उसी पर ख़त्म कर दे रहा हूँ सर। और दूसरी बात यह कि सर फार्मासिस्ट दुकानें 100 खुली हुई हैं, फार्मासिस्ट एक भी नहीं है, सबका नाम वहाँ पर उसका फोटो सटा हुआ है 100 में।
आपका प्रश्न हमने देख लिया, समय तो हो चुका है। कालरा साहब एक सेकंड प्लीज प्लीज प्लीज। अगर इससे रिलेटेड है तो मैं उसको छोटे संक्षिप्त में कवर कर लूँगा है। तो जो परसेप्शन है, परसेप्शन तो बदलने में समय लगेगा, धीरे धीरे समय लगेगा। एक जो सरकार और बड़ा प्रयास कर रही है क्वालिटी मेडिसिन को प्रोवाइड करने के लिए, वो है अमृत का। 300 स्टोर खुल रहे हैं। अभी पिछले सप्ताह में मंत्री जी ने एक अपने पार्लियामेंट में वक्तव्य में कहा था कि 20 करोड़ की दवा को खरीदा गया, जिसमें स्टेंट्स भी इंक्लूडेड थे, दूसरी भी कोई इम्प्लांट्स और भी इंक्लूडेड थे, और उसकी जो कॉस्ट गवर्नमेंट को पड़ी वो 7 करोड़ रुपए की पड़ी, और गवर्नमेंट उसको प्रोवाइड कर रही है। ज़्यादातर दवाएं गवर्नमेंट के NRHM NHM स्कीम के थ्रू फ्री ऑफ कॉस्ट सप्लाई की जा रही है। पर थोड़ा परसेप्शन अभी है। ये फार्मासिस्ट वाली जो कमी है, ये हमारे नोटिस में पहले भी आया है मुद्दा। इसमें दोनों ड्रग रेगुलेटर्स और फार्मेसी प्रोफेशन में जो पार्टिकुलरली ड्रगिस्ट एंड केमिस्ट है, उन दोनों के व्यू पॉइंट्स है, उसमें थोड़ा समय और लगेगा, इसको थोड़ा देखेंगे। आई थिंक वी कैन हैव लास्ट वन क्वेश्चन। चलिए आप बताइए।
ग्रास रूट पे हम लोग कंज्यूमर मूवमेंट से जुड़े हुए हैं। मैं आपको यहाँ बताना चाहूँगा कि डॉक्टर समित शर्मा राजस्थान में एक बहुत हिस्टोरिकल उन्होंने काम किया, और राजस्थान के सभी हॉस्पिटल्स में उन्होंने फ्री ऑफ कॉस्ट दवाइयाँ पिछले 4 साल से, और अभी तो सारी जांचें भी वहाँ फ्री कर दी। मेरा सवाल इतना सा है, वो लिस्ट लगाई हुई है 189 ड्रग्स की, कि आवश्यक जो दवाइयाँ हैं वो सिर्फ 189 है। तो सर ये हजारों दवाइयाँ की कंपनी इतना क्वेश्चन था।
प्रश्न आपका समझ गए हैं। एक नेशनल लिस्ट ऑफ एसेंशियल मेडिसिन बनती है एक हर राज्य में, क्योंकि थोड़ा हमारा तो देश विस्तृत है, बड़ा है, कॉन्टिनेंट साइज है, तो कॉन्टिनेंट साइज होने के नाते जो बीमारी यहाँ होती है वो दूसरी जगह में नहीं होती, तीसरी में नहीं होती, चौथी में नहीं होती। तो उन्हीं 376 दवाओं में से स्टेट में एक EDL बनती है, एसेंशियल ड्रग लिस्ट, और जितनी EDL में दवाएं आती है वो सारी दवाएं फ्री ऑफ कॉस्ट सरकारी अस्पताल के माध्यम से उपलब्ध कराई जाती है। तो उसमें विस्तार भी हो सकता है, हर वो विस्तार करने का काम फिर स्टेट गवर्नमेंट का है। देखिए, जब बिजनेस है, बिजनेस को तो आप स्टिफल नहीं करेंगे, इंक्रीमेंटल इनोवेशन होता रहेगा, हर साल थोड़ा बहुत चेंजेस आता रहेगा दवा में, उसमें होता रहेगा, उसके रीजंस कई हैं, तो इसमें इस चर्चा में हम नहीं जाएंगे। लास्ट क्वेश्चन आई थिंक, सो डॉक्टर समानी बिफोर यू चिप इन, आई थिंक एक क्वेश्चन।
सर, मैं सुरेंद्र वर्मा चंडीगढ़ से हूँ जी। आई एम सेक्रेटरी कम ट्रेजरर ऑफ द कंज्यूमर कोऑर्डिनेशन काउंसिल। मेरा एक छोटा सा सवाल है, जैसे आपने कहा था बिजॉन मिश्रा जी, ही इज़ रिप्रेजेंटिंग अबाउट 91 कंज्यूमर ऑर्गेनाइजेशंस, तो क्या हम एक कंज्यूमर्स की एक्सक्लूसिवली वर्कशॉप कर सकते हैं, ट्रेनिंग वर्कशॉप, उसके बाद हम स्टेट्स में जाएं, जैसे डिफरेंट स्टेट्स रिप्रेजेंट कर रही हैं, जहाँ पे उड़ीसा भी है, बंगाल भी है, पंजाब भी है, हरियाणा भी है, एंड आई एम रिप्रेजेंटिंग 3 स्टेट्स, पंजाब, हरियाणा एंड हिमाचल प्रदेश। तो पहले भी हम ऐसी सेफ मेडिसिन के ऊपर वर्कशॉप कर चुके हैं, चंडीगढ़ में भी और अहमदाबाद में भी, जहाँ पे कंज्यूमर का रिस्पांस बहुत अच्छा था। इसमें कंज्यूमर अवेयरनेस भी होगी और साथ में जो फार्मास्यूटिकल कंपनीज हैं उनको भी माइलेज मिलेगी। थैंक यू वेरी मच।
नहीं, हम तो केवल शर्मा जी को यही कहेंगे कि हम लोग इसका प्रयास में हैं, इसलिए आप लोगों सबको बुलाया गया है, और आप लोगों को मालूम है कि आप लोग यहाँ आए हैं 2 दिन से, यही जानकारी लेके जा रहे हैं कि आप अपने प्रांत में क्या करेंगे जब वापस जाएंगे। तो शर्मा जी से हम आज भी पर्सनली आप लोगों के सबके बिहाफ में ये रिक्वेस्ट कर रहे हैं, और हम करते रहें। शर्मा जी वैसे मदद कर रहे हैं, जब एक बार उनका जो पॉलिसीज़ है वो एक बार स्ट्रांग हो जाए, तब वो एक नेशनल वर्कशॉप करना चाहेंगे कंज्यूमर्स के साथ, और वो करेंगे, बहुत जल्दी करेंगे। और थोड़ा सा और धीरज रखिए, वो होगा ज़रूर, बिकॉज ही इज़ इंटरेस्टेड।
रेगुलेटर का मैंने लास्ट वर्ड बोला था, तो ये रेगुलेटर का लास्ट क्वेश्चन भी और आंसर भी हो गया है।
नहीं सर, एक दो आई एम रेगुलेटर, मैं रेगुलेटर होने के बावजूद भी एक कंज्यूमर हूँ। अभी मैं कंज्यूमर की साइड से बोल रहा हूँ, और एज ए कंज्यूमर द एक्सपीरियंस विच आई हैव गॉट एज ए रेगुलेटर, इसमें 2 चीज़ें हैं, एक तो मेडिकल केयर और मेडिकल केयर प्रोवाइडर, और दूसरे है मेडिकल प्रोडक्ट और मेडिकल प्रोडक्ट प्रोवाइडर। मतलब दवाइयाँ बनाने वाले और दवाइयों की क्वालिटी और दाम, डॉक्टर और जो डॉक्टर प्रोसीजर करता है वो केयर। अब ये दोनों चीज़ों की क्वालिटी और दाम, पेशेंट को इसी से मतलब है, वो ठीक है या नहीं। इसके लिए WHO से लगा के, हिंदुस्तान से लगा के, सारी दुनिया में गाइडलाइंस बनती है, पॉलिसीज़ बनती है, जो कुछ समय के बाद रूल्स में परिवर्तित हो जाती है। रूल्स के लिए ढांचे बनते हैं, जिसको लेबोरेटरीज रेगुलेटरी सिस्टम कहा जाता है, सब कुछ होता है, सब बन जाता है, सब कुछ। पेशेंट को फाइनली एश्योरेंस चाहिए होता है। अगर कोई नियम को तोड़ दे, पॉलिसी को ना फॉलो करे, गाइडलाइन को ना फॉलो करे, रेगुलेशन को ना फॉलो करे, तो हमारे देश में ऐसी कौन सी व्यवस्था है जो इसको रोक सकती है, और उस व्यवस्था की वास्तविक हालत क्या है? रोज 90% नियमों को, पॉलिसीज को, गाइडलाइंस को तोड़ा जाता है, और ये सारी चीजें कौन रेगुलेट करता है? रेगुलेटर का मतलब सिर्फ सर्टिफिकेट विड्रॉ करना तो नहीं है, गाइडलाइन पॉलिसी बनाना, ढांचा बनाना, जांच कर देना, ये नहीं। उसके बाद क्या होता है, वह हमारी देश की असल समस्या है। क्योंकि जब फिक्स डोज कॉम्बिनेशन जो खराब थे, जिसको बैन किया गया सरकार ने, उसके बाद एज ए रेगुलेटर तकरीबन 6 महीना में हर रोज कोर्ट में खड़ा रहा। हमारी व्यवस्था यह है कि कोई भी पॉलिसी, गाइडलाइन, ढांचा आप कितना भी बढ़िया बना ले, अंत में जाके उस कुएं में जाना है आपको, जहां पर 30 साल लगेंगे फैसला मिलने के लिए कि भाई इसने मेडिकल केयर ठीक नहीं दिया था। सर, इसको भी अगर हम जोड़ ले हमारे प्रयास में, अनलेस देयर इज अ गुड डिटरेंस फॉर गुड गाइडलाइंस एंड गुड पॉलिसीज, थिंग्स मे नॉट वर्क। थैंक यू।
डॉक्टर सुमानी की जो सजेशन है वो तो मतलब एकदम सही सजेशन है। जो लॉज का रिवीजन हो रहा है, रूल्स का रेगुलेशंस का रिवीजन हो रहा है, वो उसी एंगल से हो रहा है। और उसमें मेरी सबसे ये रिक्वेस्ट रहेगी दैट ऑल ऑफ अस नीड टू चिप इन नाउ दैट वी आर completely overhauling the regulatory structure. We are going to bring in the best in the world by learning from all the good governance practices everywhere. So I think we need to do a lot. With that, I think I will just sum up in half a minute. There is a lot that has happened. There is a lot that needs to be done. The journey has just now begun. And we have been in a position to identify a number of stakeholders, all of us here within the country, many of the consumers, many of the producers, manufacturers, patients in the hospitals, clinical establishments and others, and beyond the country also, because India is just not the pharmacy of the world for providing medical products in India. We are impacting the health and the health outcomes all over the world. So therefore, we have to put in a robust structure. Government has last year approved a scheme, and as part of that, we have been strengthening our structures to a large extent. We have to spend 1,500 crores on this activity also. So in that journey, all suggestions should come, and you must hold all of us accountable for what we are supposed to do. And if we don't deliver, you have all the right to go to the media, criticize, meet us. And when I say accountability, I was just mentioning when we are sitting over here to Bajon Mishra also, that we are going to review your accountability also, what you have been able to deliver, what has been the outcome, and why things are so bad despite existence of organizations such as yours. So accountability has to be all encompassing, and only then we will be in a position to ensure the quality. I am thankful to all my co-panelists for bringing in a definite and a different insight. Thank you.
Thanks for the nice discussion. Now I request our chairpersons to please present the mementos to our speakers. Dr. K.L. Sharma to Dr. Gupta. Dr. K.L. Sharma to Dr. Linda. Professor Mishra to Mr. Sandeep. Dr. Singh to Mr. Rajiv. Now I request our CEO NABH Dr. K.K. Kalra to please present the mementos to our chairpersons. Dr. Kalra to Dr. K.L. Sharma. Dr. Kalra to Professor Mishra. Dr. Kalra to Dr. Singh. There is also a token of appreciation from one of our sponsors, Cat Salt and Spices, for the speakers.
I was mentioning that we are missing out on our lunch.
Thanks everyone for participating in the session and taking out your valuable time and sharing your knowledge with us. Now we can proceed for the lunch. And I request everyone to please share your feedback on the link provided on the screen. Thank you, everyone.
Reason is that the two sessions, they went for a little longer time, and just now, just 10 minutes back, they have been from the Sovereign Hall 1 and 2, that these halls have been vacated and people have gone for lunch. So we are just waiting for them. They have their quick lunch and then they're going to be joining us here. There is also a slight further change in this session. We are going to be having 3 presentations, the award-winning presentations which are going to be presented. As we announced earlier, we were to be presenting also the gold and the silver awards in this session. But because in the valedictory we have the Honorable Minister for MSME, Mr. Kalraj Mishra is going to be joining us, so we thought that a few of the awards, if they are presented by him, it's going to be definitely encouragement to the awardees. So the gold and the silver awards are going to be presented by the Honorable Minister in the valedictory session. That's going to be at 4 o'clock. Right now, as another, I think, 5 to 10 minutes, we are going to be starting with this session. A very important session once again, as we have the 3 award-winning case studies which are going to be presented. We are also going to be presenting the BMO accreditation and the certificate of merits which are going to be presented, along with the third certificate which is going to be presented during this. The ISO 17024 accreditation certificate is also going to be presented in this session. The awardees, you are requested to kindly take your seats on the extreme, that is my extreme right-hand side and the extreme left-hand side of this hall. So kindly be seated, and accordingly, I think our representatives have already guided you how to be seated, and as your name is called upon, you're requested to move up on the stage from the steps which are right in front of the podium and disembark the stage from the other side. Are going to be presented at 4 o'clock. But there has been a concern by, I think 3 or 4 awardees did come to us that they have their flights to catch. We are going to be presenting their awards in this session, but just a request, if you can just get back to me, people who have their flights, just let me know your organization so that we can present your awards in this session.